I'm working at Barcelona, at the Barcelona Institute of Global Health with Michel, and I have done work on occupational and environmental exposures in relation to cancer, respiratory diseases, also using a lot of biomarkers. And this first talk is a general talk on epidemiology and occupational health, what we're doing, what we would like to do, what we have achieved, how important our research is in this area, and why we are promoting a coordinated approach, international approach. So I will talk about the development of occupational epidemiology and have a few slides also on occupational cancer and occupational respiratory disease, but a very few. This is not a lecture on these topics, and then talk also the second half on the need of coordination. So if we think of occupational exposures and we think generally about risk factors for disease, we could classify them as preventable or non-preventable. Genetics is not preventable. You are born with, with whatever genes you are born. While occupation or smoking is preventable. It's something you do. It can be involuntary and voluntary. And again, these distinctions are sort of schematic. Tobacco, you smoke, although there are clearly background factors that make some people more likely to smoke than others, socioeconomic factors and stress and whatever. So still, it's useful to have this classification because occupation is actually involves involuntary exposures. You work because you have to work to live, and you may be exposed, and it's basically preventable. We know a lot about exposures, and so occupational exposures are among the type of factors that are high priority because they are involuntary and they are preventable. This is again schematic. We have the exposures in the x-axis and whatever biological response in the y-axis, and in general, the population at large have fairly low exposures. People working in the work environment higher, and you may have an accident and you may have even higher. This is not always so, and we know it from air pollution that the general population is going to have far higher exposure in some cities than what we have in occupational exposure, but mostly it's like that. So one of the positive or negative for the workers, positive for us epidemiologists, is that occupational exposures can be high and we can have exposure contrasts. So in many situations, this is one of the examples. So I've just selected this because I think this is the first paper we have together with me a long time ago. So 1991, and this is on a type of herbicides that are contaminated with dioxins. And we are all exposed to dioxins, to TCDD from food. And but we are exposed at low levels. And it's very difficult to do a study on dioxins in the general population. It's easier to do it in the occupational population. And this study, together with other studies in animals, experimental and other epidemiological studies, but this study was an important one, helped classify dioxins as a human carcinogen and actually helped to evaluate what levels should we aim for the workers and for the general population. So we are using the studies in the occupational environment not only to legislate and to do policies for prevention in the occupational environment, but also for the general population in many occasions. Let's talk about the development of occupational epidemiology. Occupational epidemiology has a long history, and it started with fairly basic studies, case series. So somebody saw something strange, too many cases of leukemia in a workplace, reported it, or SMR, standardized mortality ratio studies that compare the workers in a factory with the general population without taking into account confounding, without too much sophistication. So, and these they were informative. They are not very elaborate in their design but they're informative because they were done in a situation of high exposures and high contrast in exposures, high risks. So you could find things even if you had some biases, some confounding, and what have you. Classical example, angiosarcoma of the liver in the manufacture of polyvinyl chloride. In a factory, you got 4 cases of angiosarcoma of the liver, a very, very rare tumor. You would have 25 cases annually in the whole United States, and you get 4 in a factory of about 500 people. You know, obviously something is happening. You don't need an epidemiologist to tell you that. It's obvious that it's very high. So this is a case series. And that's how we found out that this liver cancer is associated with vinyl chloride. And then there were some formal studies that showed this and experimental studies also. This is another example of the rubber tire, the Michelin factory in one of the Michelin factories in the UK, end of the 1940s. And you had experimental studies showing that some aromatic amines were associated with bladder cancer. And so the occupational health physician of this plant did a simple map, just spotted where are the bladder cancer cases. These are the rectangles you see. The triangles are kidney cancer. And then he just draw with gray the areas of the factory where you had exposure to this aromatic amine, beta-napthylamine. And what would you conclude if you were in the role of the occupational health physician? Does it seem, do we have an association between beta-napthylamine and bladder cancer? How would you evaluate that? Gray areas, exposure to this beta-napthylamine that we didn't know was a carcinogen. Rectangles, cases of bladder cancer. Do we seem to have an association? Okay, Ryan says, looks that way to me. It looked that way to the occupational health physician also. Obviously, this is a spot map. You know, if I had told you that the white areas are the areas where there are no workers, they are just warehouses, you know, maybe you would be less sure. Actually, this is not the case. There are workers everywhere. And the bladder cancer cases occurred there where you had exposure. So these are the type of situations that people were evaluating, you know, many years ago. And still we have these situations, unfortunately, in low, medium income countries. And they were easy to find. They were very high risks. And fortunately, at least for Western, for Europe, for Western Europe, we don't have these situations anymore. Oops. This is a slide by Paolo Vines, and this is an old slide, but it doesn't really matter. It's more or less from the early 90s, and he just classified all the studies, the type of studies that helped identify the occupational carcinogens. These are the carcinogens identified by the IARC, the International Agency for Research on Cancer. And so he had case reports, what we said about vinyl chloride here, or a case control study, or SMR studies, retrospective cohort studies, or mechanistic data. And at that time, most of the studies were done like, you know, fairly simple. You had people working in the factory, you compare them with the general population, and that was the strongest evidence. And the risk was so high, you didn't really care if there was confounding by smoking, by social class, by whatever, what have you. And that's how it was at that time. But things have changed, obviously. And this is perhaps one of the few situations where you can use an ecological design. Mesotheliomas, cancers of the pleura and the peritoneum. And these are cancers that mesotheliomas practically are inexistent if you don't have exposure to asbestos. This is a map of Spain, obviously, by municipality, and you map the cases of mesotheliomas, and they just occur there where you have factories where they have used asbestos. For most other cancers, except for angiosarcoma of the liver, mesothelioma, or other diseases, the occupational diseases are not different from the ones that we have in the general population. There are obviously exceptions. Pneumoconiosis are very specific to the occupational environment, but most occupational diseases are not specific to the occupational environment. So we wouldn't be able to find them with this type of approaches. We need much more sophisticated approaches. So after the first phases, a big advance in occupational epidemiology was happened in the mid-1980s. And I'm quoting here the Canadian group that was very important: Jacques Semiatiki, Michel Gerin, Leslie Richardson. And also there was another very important group in Washington, DC, at NCI by Aaron Blair, Trish Stewart, and they put some science in exposure assessment. Basically, they started discussing and making a much more elaborate evaluation of exposures. And they developed questionnaires, clever questionnaires. They started developing job exposure matrices. So these things that those of you who are working in occupation, we take it for granted. Actually, you know, somebody thought of them at some point in time and brought some science into that. Here is one of the best interviewers that I've had in the Spanish bladder cancer study. And she's posing here with all the questionnaires we're using in the bladder cancer study, occupational questionnaires, and obviously you don't go like that to a patient and a control. You know, we had it all electronic, but this was the idea that we are developing questionnaires that, depending on your clever questionnaires, depending on your answers, you go, new questions, you know, would be asked. If you're employed, you ask you're a painter, then you would get specific question for a painter. And you can elaborate on that and do a much more informative studies. And we had the development of the job exposure matrices. For those of you who don't know what are the job exposure matrices, just what you see, it's a matrix. So you have a list of occupations, all the occupations. I've selected 5 here. This is the occupational asthma matrix that Susan Kennedy in British Columbia developed together with colleagues in INSERM in Paris. You would have personnel that are care aides, and they would potentially be exposed to latex, and poultry farming workers would be exposed to bioaerosols. And so you have an a priori beforehand categorization of exposures, and you attribute that to a specific occupation. So it's a job exposure matrix. And then you have fortune tellers who are not exposed, but then you basically would just ask them and they would tell you. You don't have to tell them about their future risks. You don't have to do a study about them. And you will get more on that from the lectures of the course, and you will be introduced to this really nice tool we have in OmegaNet, occupational exposure tools, where you can get the list of different exposure methods, and I'm not going to go into that. And that was mid-80s. And then early 90s, mid-90s, we had the molecular epidemiology phase, where we started incorporating not only the advances in the part of exposure, but also advances in the part of the mechanism on the other side, on the molecular side. What happens when you have exposure to a chemical? What are the changes in the body, in the cell? And we would have this type, for example, of techniques, looking at markers like macronuclei in this example. So the cell dividing and a part of the nucleus keeping out, not being incorporated, and this could be a whole chromosome. And this is a marker of the genetic damage, and you can get it from blood, you can find it in cells in the urine, or in the occupational environment. What has been used is a lot of buccal cells. So you just scratch the mouth and you get cells from there. And this has been a big change, in fact. And this is the first monograph, that evaluates carcinogens, the official evaluations by WHO, that used this type of mechanistic information of molecular epi-studies to classify carcinogens. This is ethylene oxide. Ethylene oxide we have in many occupational environments, hospitals we were using for sterilization. We had our personnel in the hospitals being exposed. And IARC, actually, it's the first monograph I was participating, and classified the working group that the evidence in humans was not as strong, it was limited, it was not sufficient. The evidence in animals was sufficient. And in the older times, this would not let you classify ethylene oxide as a carcinogen. But then we started having all these new molecular epidemiology study on mechanisms. And the working group decided that we had a lot of evidence that exposed workers would have a number of molecular damage that could be identified. And so it was very likely that although the epidemiological evidence was limited, we couldn't say for sure that there was an association. This, with the animals and the mechanistic data, made us classify ethylene oxide as a human carcinogen. So this type of development of molecular epidemiology was extremely important, not only for advancing in general knowledge, but also for setting policy and for setting regulations. And the new phases, and we're going to talk during the course, I'm not going to talk more about these, is the issue of the exposome. We have a lecture on that, of how we are developing much more the evaluation of exposure. We connect it with the evaluation of the pathways. The issue of the pooled analysis and sharing of data, which is normal now, but 20 years ago was not like that. People were keeping the data. They were not necessarily sharing openly the data. The fact that we have much more record linkage, at least in Europe, but in other parts of the world. And we have these huge data sets and the need for developing data science approaches. Much more emphasis in recent years on cohort studies, although obviously you can do very, very informative studies, case control or others. And obviously we have also new approaches to causal inference. And we will talk about it in another session in this course. Just a couple of slides, very few slides on respiratory diseases and occupational cancer. Just a couple of numbers, and then I'm not going to go into details, but you will have the slides and you have the articles. And then I want to go to the issue of the collaborative research. So this comes from the Global Burden of Disease. We have this international working group that Tim Driscoll from Australia coordinated, and we're trying to evaluate as well as we can at a global scale what's the importance of occupational diseases, occupational exposures for respiratory diseases, for cancer, for also for injuries and for other diseases. And for the two most important respiratory diseases, chronic respiratory diseases, COPD and asthma, the estimates were 17%, so really not little, and for asthma 10%. In fact, other estimates that have been provided for asthma give a higher estimate of about 15%. For asthma, it is interesting that we have identified about 250 workplace exposures associated with asthma. And the reason why we know so much is because there is not a long latency. Actually, you have the exposure and you could have an effect, you could have an asthma crisis just weeks or months after the exposure. So you don't have to wait years and years, which makes it easy to identify. How important are these exposures? And in the wider working population, for many of them, we don't know. We have, in fact, for very few of these exposures, big studies in workers or in the general population studies that would evaluate. One of the big studies in the general population is this one, the ECRHS, the European Community Respiratory Health Survey, that has about 16,000 workers now followed for about 30 years. And this has allowed us to give some of the most secure, most valid estimates of how important is our occupational exposures. And, as always in our studies, our estimates depends on our definitions, in this case of the disease and of the exposure. And for example, when we evaluate disease only based on the questionnaire, we make an estimation that 10% of the cases are due to occupational exposures. When we go closer to a clinical definition, so it is the questionnaire and bronchial hyperresponsiveness, then our estimates is it's about 23%, which is higher than what was given by the GBD. But the GBD obviously incorporates lots of other studies. This is one study. It's an important one, but it's just one study. So let's move briefly to cancer. And the estimates from the GBD is that we have 4% of all cancer deaths are due to occupational exposures, and 3.4% of the disability adjusted life years, what we're calculating in GBD frequently. And most of them are lung cancers. Now, 4% may not look a lot, but just do a multiplication, and in fact, it is a lot. These are the incident cases in the WHO Euro region, and 4% means 151,000 cases per year due to occupational exposures, and 77,000 deaths. And basically, these are preventable. So 4% may not look a lot, but it is a lot. And if you think of causes of cancer, yes, we have smoking that causes a lot, and we have alcohol, and we have infections. But most of the causes actually cause a tiny fraction. So, and 4% preventable, most of it is really a lot. One of the problems with the GBD estimates is that it depends on the data that are available. And so the GBD doesn't evaluate urinary bladder cancer because it's difficult to evaluate, because it has a lot of causes that are for which we don't have their prevalence. And if you don't have the prevalence in the workforce, you cannot make an estimate. And urinary bladder is a common cancer. It's the second most common occupational cancer. So the GBD calculated 3.9%, 4% of all cancers. It's certainly above 4%. And among the exposures, we still are talking about asbestos. Asbestos, we know that it's carcinogen, 60 years ago, 70 years ago, and it's still the most important role. And then you have a number of other exposures. One of the reasons why we still have asbestos is this is a very nice old publication by Julian Pito, where they looked at the imports of asbestos in England. And England does not have asbestos mines, so they imported, and then in the 80s, it became evident that it was a very important carcinogen. They stopped importing. But look at the curve of mesotheliomas. It goes up, even though you stop exposure. So why is this happening? You stop exposure, and the curve still goes up and then down. Latency, exactly. It takes a long time, frequently, for the disease, for chronic disease to occur, which makes it more difficult to prevent. I will skip some slides, but I will not skip this one, because this is important. This is, again, estimates of occupational carcinogens, deaths, and DALY's disability adjusted life years by social development index. High income countries, high middle income countries, middle income countries. High middle, China, Peru. Middle would be Nigeria. And then low middle, low, many countries for which, unfortunately, we don't have data. So maybe it's like that, but maybe we just do not have data. And look at the trends. So if you look at the trends throughout the years, the high-income countries have taken some measures. The middle and high middle in the process of industrialization actually are not taking preventive measures, and the importance of occupational diseases is going up. This is cancer, but it's the same for a number of other diseases. And this is really unfortunate. And so, although we know a lot, we have taken measures of control. The most strict measures of control have been taken in the high-income countries. And I'll skip this number of slides. And let's go to coordination in occupational epidemiology. And OmegaNet is coordination. For one thing, we can learn a lot and we can do a lot without collaboration. You don't need international studies to find a cause or to find to evaluate preventive policies and to do intervention studies. But for lots of the research we are doing and for developing health policy, it's actually more efficient to do big collaborative studies. And I'll talk a bit about that. But in no way I want to give a message that this is what you should be doing. Do what's more informative. Do what you can do. But in many occasions, if you want to be efficient and have some impact from your work, you have to think big. So, and thinking big in many occasions is thinking international. We have this inventory of occupational cohorts, and Michelle and Ingrid Mellum will talk about that, so I'm not going to go into that. But through this inventory of occupational cohorts, we know we have at this point in time 140 cohorts registered, and they have information, occupational information, for more than 22 million persons. 140, and we have not finished. We're going to go, we know that we probably in 1 year will have another 100 cohorts, and this 22 millions will go, several millions higher. And this is information that is available. We only have cohorts that are active, that can be used, that can share their data. So put yourself in this perspective. We can do our own study, but there's a lot of data around, and people are willing to collaborate. So, and that's what we're trying to do with OmegaNet. So in Europe, we have the know-how. There are lots of groups that are very capable in occupational epidemiology and molecular epi. We have the numbers, millions of participants with occupational information. What is interesting, we have varying work circumstances that is good and bad. Why is it good and bad? It's good because you have varying circumstances. So this, having contrast is important in our studies to find effects. It is bad because it's more complex, obviously. You have to be aware of these differences. We have dispersion, a few big groups, lots of small groups, all around, lots of workplaces all around. And we have in Europe many poorly studied populations. Much of the research is concentrated on a few countries. So there's a lot of possibility to do work, find new associations, and also use this knowledge to develop policies. So why should we collaborate? Statistical power, efficient design, replication, and helping promoting research across Europe. And obviously a prerequisite for collaborating is that we harmonize our methods. You can take stuff that are around, but if they are too different, it doesn't work. You have to harmonize your methods. Statistical power. There are some diseases that are common and you don't need huge studies, but there are many diseases that are not common. And there are some exposures that are common, but there are many exposures that are not common. So, and we're interested on all of that. We also are interested in subpopulations. You may be interested in young workers, or you may be interested in work-life situations, and you're interested on working mothers. So smaller populations, and we're interested in interactions. How this lifestyle combined with occupational exposures? How does one occupational exposure, say to chemicals, combine with night shift? Or how does an exposure combines with the genes? And so for interactions, you need big numbers. And obviously, we're interested in dose response analysis and on risk assessment. And for this, you need bigger numbers than just a yes-no story. Efficient design, and Ingrid and Michelle will come back to that in their lectures. Starting with 22 million gives you a lot of capacity. So you have populations with different environmental, occupational, cultural, genetic differences. And if you, and this is certainly, you can see it as a problem, but you can see it as an asset, in fact. And if you know you have the situation, you have a big sample, you can try to develop designs that are as clever as possible. Replication. This is, we're discussing a lot the issue of replication, and it is definitely important, no doubt. But probably it is less important than sometimes discussed. And sometimes the issue of replication has been used to discredit valid research, saying it has not been adequately replicated, etc. Let me show a couple of slides on this. The story of replication came a lot to the forefront through the genetic epi studies initially. And John Ioannidis from Stanford has done some magnificent studies showing how more you accumulate numbers, in this case is genetic subject or alleles, the odds ratios tend to go towards the null. And he has been, he's a champion of this whole story, saying that we have a lot of wrong evidence going around. And he's, I think, he's a friend of mine, and I think personally that he's taking this message far too much, because we do have a lot of findings that are never replicated, but many others are replicated. And in the end, when you do an IARC evaluation, you never do an evaluation based on one study. You do an evaluation based on many studies on not only humans, animals, mechanistic. So it's very difficult to get it wrong if you put together lots of studies. But certainly there is an issue of replication for single studies. And we can have differences because of population characteristics, simple constellation of different factors, end up with different associations. You may have simply differences in studies design, and you may have chance due to multiple testing and publication bias. So, having big studies with the same protocol avoids some of these issues. Finally, why should we collaborate? Because we want to promote research and know-how within Europe. We want to develop research capacity. And we have lots of groups. Few groups are very big, but there are lots of groups who, even though they're not big, they are really great research groups. They may have capacity in one area on omics, not on exposure assessment, or they may be very good in exposure assessment but have no idea of molecular epi. So you do this type of collaborative studies, and you bring together know-how, you talk, and you increase your capacity. So what type of collaborations have we been doing? Just to finish, we have been doing for a long time ad hoc coordination of specific projects. For example, the ECRHS that I've Isaac in children for asthma, and many others. The studies that Michelle has been doing on radiation and many more. But what we're trying to do now is to put together in a much more permanent basis. So long-term multi-purpose European occupational cohort coordination. So what we're trying to do is to do a virtual mega cohort where you will be able, not necessarily use 22 million for all your hypotheses, but sample from there and try to know how harmonized the protocols are. So this is one of the aims of OmegaNet and of some other projects on coordination. And obviously, we can initiate new large international cohorts de novo. The problems is that we need funding, central funding, and for the moment we have this funding to do this. Some people are afraid that if we collaborate too much, this may stop creativity because we are all using the same protocol. I mean, this can be a problem, but it has not proven to be a problem. And local groups are still doing their own initiatives, and if they are positive, then they try to make it bigger. And obviously time. I mean, this is a real issue. It takes longer to do a big international study than doing a small national study. I mean, this is evident. Now that I say it like that, it's obvious, but this is an issue. And it's an issue also for the big studies when you have PhD students and they have to do their dissertation, and you have to get the whole international data, and not all the data is coming. So it is a real issue, the issue of timing. It takes longer to do the big studies. So the future. We have, I think, a pretty good future in this area because there's a lot of things happening, lots of groups, very, very good data. There's a tendency, acceptance by European epidemiologists to collaborate. So close coordination that combines existing and new cohorts is a fait accompli. It's happening. We have enough power to evaluate hypotheses, and we have sufficient know-how. Maybe our group, Michel's and my group, are not great in some aspects, but we know something, and the guys in Karolinska know something else. And so altogether, we have sufficient know-how, and we can make maximum use of this data to do more efficient and conclusive studies and use of the studies for policy. And I will finish here. Thank you.
Wonderful. Thank you so much, Manolis. That was a great talk. Maybe I'll ask Ariadna if she can stop the recording now.